A very good morning to esteemed ophthalmologists, teachers, professors, and my dear friends. Once you heard Dr. Atik talk about how to place an IOL, I'm going to give a few gist of what kind of an IOL do you want to place. As we all know that there are many types of IOL in the market with different toricity, either it is anterior or posterior, angulation, and what all types of T1, T2 they have. So I'm just going to give a gist of all the types of IOL which are available, and the choice you can choose it according to the patient as well. So mainly I would like to categorize them as monofocal, multifocal toric IOL, and even sulcus fixated toric, which are available for patients who are aphakic. The parameters for toric IOL, usually what I do for all patients is the keratometry, the incision size and location, which has to be done according to the astigmatism. The anterior and posterior curvature of the cornea, which is very important as the posterior corneal astigmatism comes into a place. And the lens thickness with the white to white for few of the toric IOL is also important. In the monofocal toric, you have the toric with the blue filter, the clear toric, and also the preloaded toric IOLs. To come with the toric with the blue filter, you have the Alcon, the hydrophobic acrylic, which the asphericity is anterior and the toric design is posterior. That is a spherical aberration of minus 0.17 with a total size of 13 millimeter with an optical size being 6 millimeter. The incision, it can be going through a 2.2 or a 2.8 mm incision. By aligning the markers to the steep meridian of the cornea, the lens is designed to address the astigmatism of the patient. So always while marking, as Dr. Atik said, make the incision go through and through, because sometimes if the pupil constricts as well, these markings will be helpful. And then you have all the models, as I said, from T2 to T9 according to the cylinder astigmatism. And as the T increases, you will see that the cylindrical power in the corneal plane, IOL plane also doubles. The unique feature is there is a good range of cylindrical correction available from T2 to T9 at the IOL plane. Coming over to the upper supraphobic toric IOL, which is also a hydrophobic acrylic with 0 degree angulation and muscle shaped. The advantage of the muscle shaped is that it is actually longer in size and it doesn't stretch the bag, which causes an elliptical shape. So once placed in the bag, it takes the whole contour of the bag and it keeps the IOL more in the center. The toricity is anterior for these kinds of lenses, which is preloaded with an advantage, and it can go through a 2.2 incision as well. So here also you have the different types of toricity according to the corneal and cylindrical plane. And the unique features, as you can see, is it is preloaded, cost effective, and the advantage of the muzzle shaped haptic design. And now to the IOCare, which is a hydrophobic acrylic, both the optic and the haptic material, with a modified C-shaped and with a spherical aberration of minus 0.18. And the optical design you can see here is also anterior, a total size of 12.85 millimeter, and this has to be loaded as a normal intraocular lens. The unique features are the wide range with a 0.5 step from 1.5 to 6.5, and it is cost effective as well. Now coming over to the plate haptics, the IOCare Ultra Smart Toric, which is customized for the patient. And one of the main feature is this is a biconvex toric, which is plain in both. So even if you flip and put by mistake, you will have the toricity. The material is hydrophobic acrylic with a negative aspheric aberration. And why it is customized is it takes the shape of the bag as well. So that is why you will have to give the white to white also for calculating these IOLs, the axial length, the anterior chamber depth to calculate, and fits exactly in the capsular bag. The lens position is also optimized in this. And it has, one more main thing is you don't have to rotate. These lenses, if you try to rotate too much, it does tear the capsule. And they have placed it in a way that you have to place the lens only at 0, 180. That is one of the main advantages. The AMO thickness toric, which is a hydrophobic acrylic, aspheric anterior, the toricity is also anterior with a spherical aberration of minus 0.18. The total size is 13 millimeter and it goes through a 2.8 incision, which requires a loading as a normal lens. The unique features is only the clear optic hydrophobic toric, and the spherical aberration maximum it corrects of minus 0.27 with a high Abe number, and chromatic aberration correction is always better. The Zeiss toric, you have it is a hydrophilic acrylic with a hydrophobic surface, which is a plate haptic with a zero angulation. The only thing is this requires loading, and it actually can be rotated clockwise or anti-clockwise without causing any harm to the capsular bag. Then we come over to the multifocal torics. So as you all know that it has both the diffractive and the refractive index. You have the Restore multifocal, which has a +3 and a +2.5 add. The +3 in the center, you have the 3.6 millimeter of a diffractive, and then periphery of around 2.5 you have the refractive. And you have 9 diffractive rings which are suitable for patients who want a range of near, intermediate and distant vision. The +2.5 add comes with a central 3.4 millimeter diffractive, peripheral 2.6 millimeter is refractive, and with 7 diffractive rings for all the different ranges. It also has a variant of T2 to T5 with different types of near vision for each type of lenses according to the corneal or the IOL plane. The unique feature is one of the only multifocal toric which is available with a near option of add. You can either put +3 or you can either put +2.5. The AMO Technis multifocal toric has an overall diameter of 13 millimeter with an optic of 6 millimeter. The power ranges from 5 to 34 diopters with a 0.5 increment. The near add is +4 and it has clear optic. And finally the Zeiss multifocal toric, which has a diffractive of +3.75 at the IOL plane, and it goes through 1.8 millimeter incision. You have a wide range with the increment of 0.5 cylinder with the spherical and the cylindrical correction, customized to every patient, so the white to white is definitely mandatory. Calculation of white to white is based upon each individual. Either it can be due to the digital caliper, which is what I use maximum, or it can be either done by the OBSCAN as well. The IOCare Acryol toric multifocal IOL, which has a multifocality in the anterior surface and the toricity in the posterior surface. So always these lenses you should make sure that it doesn't flip open while it opens in the bag. We should all know that all kinds of toric are similar, but they are not same. It has to be designed according to the patient's posterior corneal astigmatism, whether with the roll, against the roll. Always make sure that as age progresses there are change, and each IOL is unique. So choice has to be made on patient on individual needs with IOL power and the patient's affordability. I'd say that the cataract surgery is no longer like a patient walks in, they don't say that they want a cataract surgery. They actually want an astigmatism-free, fast healing, micro incision, laser assisted, no glass, no glare, 6/6 N6 cataract surgery is what patients want nowadays. I thank you all, and a special thank to Dr. Arul Murali Varman and Dr. Umesh Durairar.